Because we were all used to 700 servo 900 cc, you know. We had these old big machines which we used to 900 cc, we used to alter, and we used to wonder what this ASV is, because something very interesting, you know. And they told it introduction to ASV was it is no mode. It is no mode. This was the introduction to us. The introduction was it is no mode. It didn't have a main name. It is no mode. Means you don't have a mode in it. You just have one button that you have to press. This is what was told to us. There was only one button. So it was very interesting because you are moving from a very important way of ventilation to a very different way of ventilation. What is the difference between ASV and this is? It is open loop versus closed loop. Okay, open loop versus closed loop. That means to say, in an open loop, like for example here in the CMV, the pressure is telling us what is happening. Then we are going and saying, okay, the pressure is high, let us do stabilization, let us do this, let us do that. We are thinking, right? If by any chance I want to wean the patient, I have to decide, okay, the pressures are okay, let me reduce the PEEP. Let the PEEP come from 12 to 8 to 8, then let me wean off. Then I want to, when I finish that, then I want to see, okay, now it is okay, now let me convert to pressure support. Now after pressure support, okay, it's better, now let me do a SBT. So we are going on an average more than 200 times onto the ventilator. If you want to do the ventilator properly, in any given patient, the average number of times that you visit the ventilator is 200 times. How many? 200. 200 times. Okay, that is the average number of times that you touch the ventilator. So this moves from a situation where we don't have so much ventilation times to a situation where everything is done by the machine. Okay, everything done by the machine. So that's the beauty of ASV. Okay, understood this much till now? Okay, are there any other systems like that? So now we've understood that this is doing something like this. So what it is doing is, start okay? It is doing this breath by breath. It's doing this breath by breath. It's not inside a breath. You understand? It is breath by breath. Okay, so you have one breath, second breath, third breath, all done breath by breath. When you have the control intra-breath, inside the breath itself, it is called as proportional assist ventilation. It's PAV. So if you go to PV 840, that's a ventilator that is Puritan Bennett. Okay, that will show you something called proportional assist ventilation of PAV. Okay, that is intra-breath. You must understand this. Okay, intra-breath. That is एक breath के अंदर ही control करता है वो. Clear on this? What is PAV? This is breath by breath. That is intra-breath. Okay, and there are knowledge-based systems which are other closed-loop systems. What are knowledge-based systems? It will look at a parameter and change the ventilator. For example, our Evita XL. We have a machine called as Evita XL in our ICU. Okay, the Evita XL has got a carbon dioxide that comes from back. You put that carbon dioxide onto the patient, and as per the carbon dioxide, the machine changes the parameters on the tidal volume and the respiration. That is called as Neo Ganesh. On the ventilator, it is called as Evita Smart XL. Understanding? Neo Ganesh and Smart XL. Okay? You know that? So that is closed loop. You understand? What is the loop over there? Closed loop. Okay, the carbon dioxide is increasing. I am changing one parameter. So it's a kind of a small closed loop that you are having. You understand? PRVC. It's a kind of a small closed loop where if the pressures are going up, I am changing the flow characteristics so that I get the pressures very well regulated and give the same volume. Knowledge-based system ho gaya wo, where a small closed loop from the ventilator is going to, from the patient is going to the ventilator saying that the pressures are increasing, reduce my pressure. Your pressure control ventilation is a knowledge-based system. Why it is pressure control? Why is it knowledge-based? You have set a pressure. The pressure is say 20. Okay, and that pressure, to maintain that pressure, there is a continuous feedback going saying that sensor mein 20 maintain karo. That's a closed loop. But these are only 1 parameters. If you notice what I'm talking about, is 1 parameters that they are changing. So if you want to put all of these together in such a way that everything is taken care of, when I said Smart XL, only ETCO2. When I take off pressure control, only pressure. When I take off pressure regulated volume control, pressure and volume. If I want to do everything together and ensure that the patient is safe right from intubation to extubation, the only mode that is presently available is ASV. Barabar? Anything wrong? Yeah.
adaptive zone ventilation. So it is one of the closed loop ventilation mode. So I'll just show you the background also for exactly. So we'll be understanding that what exactly ASV is, and we are also going to understand what is the difference between the conventional modes and ASV, and the basic demonstration of the ASV, and we'll be able to identify in terms of other similar modes. So we know about the conventional modes. We always use volume control, we always have pressure control modes, and we know what volume control does, and also we know what pressure control does, right? So here we are setting the volume and pressure varies, and here we set the pressure, the volume varies, which is all we know. And in this, there is no feedback systems. Okay, it is we as a user, we go at the machine, we analyze the patient condition, and we according to that we titrate the patient
so
settings.
the loop over there, the loop in such modes, it's got a loop, okay? It's got a loop. It's a fairly physician-based closed loop. You understand? It's a physician-based closed loop. So, for example, I set a volume. Okay, I set a volume. I show the loop how is it. Okay, if I set a volume, the volume shows a pressure differential. The physician here completes this by looking at it, and then the physician comes inside and changes the volume because the pressures are high. So this is a closed loop system with a physician in the middle. You understand what I'm saying? Don't look at it as a literal meaning of that. It's a closed loop. This going in together, two catheters going. ऐसा नहीं है. Okay, the loop is, the theoretical loop is, there is a volume, the pressure changes, the physician comes in the middle. Similarly, in pressure control, the pressure is, you have a constant, the volume changes, the physician comes in the middle. So the loop involves a physician.
Okay. Of course, there is a loop, but it is called an open loop.
Yeah, this is open loop.
Because it is we all who control this, I mean, as a clinician. And then after, as per the patient's, but this is a closed loop where it will, again, ASV is not completely closed loop. Okay, because what completely closed loop we have is the intelligent. Okay. Now we know this conventional mode. Now, what are problems with the conventional mode? That you know, the ventilator settings appropriate for one point of time may not be optimal with the patient's.
If you put such graphics in the brain, we will not listen to that. All of us will look at that rather than that.
Sir, you learn what is it?
It's probably
They are more diverted.
That always comes. That one always comes.
It has a baby also. That feature.
हाँ क्या?
अच्छा वो सबसे तभी नहीं था स्टार्टिंग में
Starting में नहीं था.
Next day.
So when we have,
Give this feedback to people to remove this graphic.
I have put that.
You put it. Because what happens is you are not reading this. Everybody is looking at that.
इसके बाद में नहीं आएगा. So basically all the conventional modes, when we do a ventilator setting appropriate for one particular point of time, which may not be optimal for all the time.
It just reminds me, just before I forget, this Hamilton Academy करके एक academy है. If you want, you can join it.
Yeah, I told them.
You told them. So you can join it. It's a login and registered. In that there is everything, teaching, everything is there. You can join. Very beautiful courses, very beautiful ways to understand. Of course, it takes a long time, but you can join it. It's there. Hamilton Academy. They also have regular webinars and you can actually attend.
I'll just help all the friends to do that. In the group, I will share the link and all that. So as we know that that all the settings what you do, it will not be appropriate for all the time, and only deliver set parameters and which will not take any feedback from the patient side and do the variables and change the variables. Now, thus all the classical volume pressure control are the open loop modes, which has sort of no feedback, and the loop you as a clinician fill that loop as I explained. Now, so actually it's not a problem, but it would require more intervention, more monitoring, okay, and you have to be there like for very much time to see the change and then accordingly operate. But with and it of course requires continuous monitoring, as I mentioned. It requires also some, as Sarmas have highlighted initially, it requires also heavy sedations, and with that it also will prolong your ICU stay. Because all the open loop we are going with the open loop modes, we are going with the flow. We start with the mode, and then we change the mode from the passive to active modes. Okay, and for that we will of course require more intervention.
Yeah, because when a person is on assist control mode, it's not him not controlling. He's controlling one aspect of the trigger. Otherwise, he's not controlling anything more than that. He's not controlling the volume. it is so difficult for a person who is now awake but sleepy, to actually coordinate with the ventilator because it's not his respiration. It's really not his respiration, isn't it? So it becomes so difficult. That's why these people require escalating dose of sedation, or we are left with the situation you tolerate it. Are you understanding? Yeah.
So in that context, of course, why we need the advanced modes? We need, because the conventional modes are more uncomfortable in case if we do not really, monitor the patients very aggressively or very much frequently. It would require less, sedations and paralytic drugs. It can ventilate and oxygenate more effectively because it will finish the loop on its own and adapts on its own. And then it will have a better ventilator-patient synchrony, which is something, very important point. It is also observed that if you use the conventional mode, because we know that as for the patient synchronization, we change the mode. Okay, initially we start assist control, and then we see that patients are awake as so said, and then we change the mode. We come back to the spontaneous or SIMD. Okay, and we try to bridge that gap more manually. But here since it is more closed loop, so the machine is going to do on its own. So you will have a better patient ventilator synchrony. And of course, if it happens, then you will have less hemodynamic compromises with more lung protective ventilation. Okay, the main part here comes is the lung protective ventilation because it is going to change as per the patient lung mechanics. Okay, there will be very less likely a chance of ventilator-induced lung injuries. So that is why the advanced mode is something which is really important to understand. And of course, more rapid breathing, so you have less ICU stay. Now, what exactly ASV is? So we now understood that why we need the advanced mode. So ASV is an advanced closed loop mode, but not fully closed loop, as I said already. And it is designed to help the user set a particular minute volume percentage as a minimum requirement, as a basal requirement for that particular patient. Okay, which will help us find out the optimal breathing pattern based on the lowest work of breathing and the minimum force of breathing. So the two equations what we use, one is Otis equation and other is Mead's equation. So Otis equation basically help us to maintain or get the optimal breathing pattern based on the lowest work of breathing, and the Mead's equations help us to help us deliver that breath as per the minimum force of breathing. Now this is the principle behind the ASV, and as I said, it is not completely closed loop. Okay, it is going to finish the loop. Again, we need the inter. So again, there is a physician here, and it is sir mentioned in the standalone ASV. So the IntelliVent I not say we don't need. We still need that because there are still some controllers in the IntelliVent which is still on the physician hand. So I hope you understood with the. So you just have to set a user defined set minute volume percentage. Okay, as per the basal requirement of that patient to start with. Okay, or as per the requirement, if you think that the patient requires more minute volume, you can set that minute volume target as per your patient requirement. And once you set the minute volume target, the machine then analyzes the patient compliance and resistance in the form of one value called as time constant. So it gives the three test breaths. It analyzes the time constant and understand what is the patient's respiratory mechanics. And as per the respiratory mechanics, it is going to make an optimal breathing pattern and it's going to decide the volume and rate. So we have a ASV graph on the machine which will tell you that what is the best possible volume and the best possible rate for this patient. Okay, and the combination of these two would give you the target volume, the minute volume what you have set as a user, which I'll show you in the subsequent slide. Now, is it just another mode? It of course is a mode, but it has more simplified settings. So it is one mode for all the patients who are breathing spontaneously or are passively ventilated. So you don't really have to change the mode from CM, like how we change from CMV to SIMV and PSV, and then you extubate. It is one mode. You can start the same mode when you intubate the patient, and you can continue the same mode.
So let's just take the example of what happened yesterday with other that patient was there, who was on IntelliVent. What exactly happened? Can you tell everybody what exactly happened? Just so that everybody realizes what we did recently. So then you can relate.
So patient, generally we been from the volume control, pressure control to the spontaneous breathing like a CPAP mode. But in the IntelliVent ventilator, because it analyzes the CO2 level, then RSBI, all spontaneous breathing senses, all. So it automatically, if the patient is ready to.
Now what happened to our patient? What happened to this patient? I don't want to know what it does. What did our patient happen?
So initially the minute ventilation volume of the patient was 100%, and the peak was.
So what it does, let me explain to you. We did not touch the ventilator. You were there? We didn't touch the ventilator. If you notice what we did with the recent case on bed number 7, we did not touch the ventilator. We just set minute volume percentage. After that, it went right from getting from active to passive to readiness to meet criteria and pressure support and spontaneous breathing trial, and told us remove the ventilator. This is what it does. It went from active, changed everything. We didn't touch the ventilator in any single time. It went from there. We went to passive, from passive to active. He came ventilated, right, on a with a Becuron given after a tracheostomy, isn't it? He came with that. We put him on ASV. We did not change from volume control to assist control or whatever pressure support. We didn't do that. We didn't change his speed. We didn't change his FIO. We just went and did it itself. And then subsequently, what did it do? I went into readiness to meet criteria. It told you it has been on spontaneous for a long time. Then did an SBT. After it did an SBT, came and told you remove the ventilator. And during the SBT, it gave you all the parameters saying, is your RSBI okay? Is your tidal volume okay? That's the background of what we did recently. He'll explain to you how he did that. He'll explain to you how he did that. Okay, you understand the background of how that patient did? Now he will tell you how the ventilator did that. Okay.
So, as I said, it is one mode from intubation to extubation, which can be used for passive patients, of course, because you intubate the patient will be passive, and then eventually when the patient gets active or start breathing spontaneously, the machine will auto switch for that from the passive to active part, which I'll explain you in subsequent this thing. Now, in terms of parameter, okay, because we need to understand that how it happens and what are the minimum parameters we set in that. And what are the important parameters which are helping us to do this? So ideally we have only 3 main parameters. I'll also show on the vent trainer later. So we have 3 main parameters. One is percentage minute volume, P and FIO. Now this, if I have to see, as I said, one mode from intubation to extubation. If I have to actually see in other modes. Now, if I say if I have a patient who's passive or the patient who's active, I either use start with volume control or PCV, then I switch to SIMD, okay, and then I go to pressure support and then I extubate. But here, as I said, you don't have to do this, it becomes one mode. And when it comes to also comparison with the settings, because we always divide the ventilation parameters, or either oxygenation, ventilation, or for the synchronization part, right? Now, in terms of the modes, if I compare all the settings, now this is a conventional mode what we see. For ventilation and CO2 elimination, we use so many settings. We set the volume, we set the inspiratory pressure, we set the rate, I ratio, okay, and support as per the mode what we are selecting, okay, what we have mentioned there. Now in this, and for oxygenation we have of course peak and FIO, but if I actually see ASV, okay, we have only 3 settings. So the entire ventilation controller is by this one setting of percentage minute volume. Okay, so you can control your CO2 elimination by this just one parameter. Okay. And similarly, but your P and FIO remains the same, like in other conventional modes. So you see there are so many settings you do, okay, in other conventional modes, and when you compare with ASV, it is one simplified setting, which I'll come back that how exactly it is to set and what is significance behind this percentage minute volume and why it is percentage minute volume, which always comes as a question. Now exactly how it takes is when you say percentage minute volume control. Now this percentage minute volume is exactly the minute volume normalized to the ideal body weight. Now this percentage option we give from 25% to 100%. Okay. 25% to 50%, and we ideally suggest to start with 100% because 100% means the normal basal requirement of the patient.
In a normal person.
Normal person. Suppose I am of 170 cm height, my ideal body weight is 66. Okay, and as per my normal basal requirement, okay, I'll have to set 100 ml per minute per kg. Okay, that means 66 into 100 becomes 6.6 liters of the minute volume. So if I set 100% for me, okay, it will target a minute volume of 6.6 liters per minute. That is my basal requirement. Okay, to start for a normal patient who does not have any issues like carbon dioxide retention or any respiratory disease. Okay, so if you want to start from me and I do not have any conditions, but you want to give me at least basal requirement of ventilation, you will set 100% of the minute volume. And how it is taking, as I said, it is going to calculate as per 100 ml per minute per kg for adults. And when you say 100% minute volume means what? That means you are trying to set the basal requirement. That means in patients who are in normocapnia at rest with normal metabolism and with normal lung function. Okay. But suppose if you have a patient who is having hypercapnia, okay, who may not have normal metabolism, okay, or who may not have normal lung function in short, you can titrate that minute volume target as per your requirement. Okay. So instead of setting 100%, okay, or instead of giving just the basal requirement, you can give more. Okay, or you can change your minute volume target. Okay, how that is done is I will also show you parallelly with the demo. I'll just show you with the demo. Can you see on the screen? So this is I'm just starting a simulator just to explain you that how 100% how you're targeting. Meanwhile, so suppose I have a normal lung now. Okay, I'm just simulating a condition just to explain how we initiate this. A normal lung I have a normal resistance and also normal compliance for this patient. Okay, and a normal metabolism I have mentioned here. The patient is passive. I suppose I want to initiate the ventilation for this. Now suppose if I want to start ASV, I'm just parallelly matching so that we all understand well. Now what I have seen in the slide, I'm going to set the percentage minute volume. And to start the percentage minute volume, I will start with 100%. Why 100%? I will show you significance here. Now this is 100% set here. My height is 170 centimeter. Okay, my ideal body weight is 66. Now so that means for adult, as I said, it will take 100 ml per minute per kg. So that means if I show you here in the controls, the machine has set for me 6.6 liters per minute of the minute volume. But you think, but this is only in case when I have normocapnia, I have normal metabolism, I have normal lung function. But suppose if there's any other patient who have increased metabolism, fever, CO2 retention, all that thing, you can change your minute volume.
So I would put it this way. So if for practical reasons, if I would ask, what would you do if there's ARDS? Let's take it this way. What do you do if it's ARDS? What do you do if it's ARDS? What if it's asthma? What is asthma? What do you do? Asthma, COPD, what are you expecting? You're expecting hyperinflated lungs. Right? So I don't want larger volumes. Simple? Because if I give larger volumes, I'll have problems. Simple? We don't want to give larger volumes. So what I will do in the minute ventilation, I will reduce it. I'll give it 80 maybe. Are you understanding? If I have a patient of hypothermia, patient has fever, acidotic, his metabolic rate is very high. So he is breathing at a high situation. We require the carbon dioxide to move out of that body very quickly. Okay, because it's a problematic metabolic problem. What do you do with that? Simple. So 100 maybe 1 maybe 120. ARDS, what do you do? Still high, no? Why low? Tighter volume नहीं है वो, minute volume है. Will be higher because you got the point.
Yes.
So in short, my understanding from this Akash is that when the patient is very sick, don't put on ASV. This is my thinking. Why I am telling you to all of you all is that patient will move from very sick to less sick. You may not change the minute volume. You will see a ventilator to a ventilator. You understanding? So I think you should say the first day you should still use your conventional mode, maybe CMB or something like that. Use that. Let the resuscitation get over. Let the patient get less sick. Then you go to an ASV mode. Otherwise, you will have alarms ringing, RR being fast, adrenaline being haywire. You don't understand really what's happening.
I agree with sir what said in the way that because we are going to start learning it again, we also have to start with a simple patient or a normal patient so that we understand it more better. Because when we start with a difficult patient and then as sir said we give alarms and all and we will also be confused.
Like for example, you take a patient who has got a cardiac surgery. You take the patient on cardiac surgery and put him on ASV. Do you think there will be problems or no problems? Why problems?
In cardiac surgery, there will be no problem.
There will be problem. Because what has happened over here in cardiac surgery is you have had a sternotomy. since your bladder has turned out, the FRC has gone down. Once your FRC has gone down, this ventilator does not know the FRC has gone down. Are you understanding? Ideally, what you want, the FRC to open up again. He's undergone anesthesia. He's undergone anesthesia, come to FRC drop by 30%. Okay, you will put 100% minute volume. It will kind of over distend the existing clays, will not be ventilating properly. You want that patient to first settle down. You know, so in cardiac surgery, because the FRC is on the lower side, the sternotomy is open, you may not get the right values. So my experience has been cardiac surgery put on ASV and these patients don't do well. They have longer periods of time of weaning. The machine just doesn't it never matches the weaning tendency. So basically, cardiac surgery avoid. If you have very sick patients, diabetic ketoacidosis is the worst case in which you put ASV. Worst case. If you put diabetic ketoacidosis, they quickly move from extreme metabolism to extreme normal. In 1 day's time, they are completely abnormal to completely normal. The ASV doesn't really recognize that. And then it creates problems, it may cause problems, potentially. Okay, so high metabolic rates and all these things, we probably want to avoid it. So my take on this matter is, as we all learn, we first start with the conventional mode. When we see the patient getting better, we move to ASV. That will reduce our frequency of going to the patient. Okay?
So what about morbidly obese patient?
No, there's a problem. She is actually right. In a morbidly obese patient, again there will be a problem with ASV. Because the chest wall is not there in place. FRCs are lower. Wherever the FRCs are extremely low, there is a problem. This is what I noticed, okay? This is what I noticed. So maybe in a morbidly obese individual, probably I'll not use it. I'll put a TPP and then use it. If I want a morbidly obese individual, I'll put a transpulmonary pressure and then use it. Then with a TPP, it will give me a right option. Just ASV on its own, no.
But eventually, maybe with the experience.
Maybe we will. But I'm still yet to see even in abroad countries, people without any problem starting. In fact, when I went to, where was this place? Sweden? France. So Toulon, I went to a place which is only having Hamilton C6s. Jean-Michel place. Okay. So one day I was there in the ICU. So the whole ICU was full of only these Hamiltons C6s, all placed on top. Not C6, C5 is it? G5. It was all placed on top. Okay. And I saw a patient coming inside. The first mode they used was always control mode. So I happened to ask Arnal, why are you using control? Just now we were talking about ASV, why are you using control? He said, no, let's not use it for the sick patients. And then he explained to me that in a sick individual, the ASV is not performing pretty well. We need the sickness to come reduce a little bit. And so a person with so much of experience, Arnal, also actually starts CMV and then goes to ASV mode. So I personally feel, at least learning from him, I think we should probably go from CMV first. Understand the mechanics. You also want to know what is the plateau pressure. You want to know what it is. You cannot know that in ASV. You cannot know that well. Understand the mechanics. Look at volumetric capnography. Look what is happening here and there. Understand what is happening with this particular ventilator. Lower your resistance, lower your compliance. Know all of these things. Then move to ASV.
But then you have a patient who's like in emergency, you have sedated the patient. With like the code blue and all. And then when you initiate the ventilation, and you start with say ASV. Because the patient is sedated paralyzed. So it is working more as a
So if you are completely paralyzed, no. If you are completely passive, then it's okay.
Completely passive.
Then it's okay. But we nowadays don't paralyze so much. No. We paralyze once and then we forget.
Yeah.
Then where we paralyze again? Unless we are doing our TPP measurement and then we don't do otherwise paralysis. So that is the issue. But but I think maybe we might be a unit which will start doing it early. Let us see. We don't know. Okay.
Okay. So I was explaining about this minute volume target. So when I said 100%, okay, my minute volume target is 6.6 as per my height and this thing, ideal body weight. So height becomes a very important factor to put in. So even if you don't have, really measured the height, I'm sure that other nurses keep the measuring tape plus, in the ICU, we need to measure the height of the patient and then insert the height. And then, because I'll tell you the change in the height. Now suppose my height is 170, but by mistake, if you're not scared and it is something different, so say I said 180, okay.
Weight does completely changes.
Now 75 become my ideal body weight, okay, and if you see my controls, my minute volume target is changed to 7.5 liters per minute. So that means it is not correct for me, okay, it's incorrect for me sort of thing. Okay, so that means very important for us to set the height first.
So that minute volume is a percentage, not really volume.
Yes.
Okay, it's percentage of 7.5. So 100%.
And it is taking 75 into 100. I mean, your antibody is 75 into 100 ml per kg for the adults, which is giving you 7.5 liters per minute of this thing. Now, suppose, as I said, that when you
But what equation is using for ideal body weight? Because it's not the same equation. What equation is using?
It's the same.
No, it's not. I just now calculated in my mind.
No, you're talking about unfairness.
Yeah. No, go behind.
height centimeter inches.
Even in centimeters hota hai, 95.5.
I calculated that.
So this equation is something different. Because see, if you look at the equation, वो अलग आता है. जो भी है, लगता है it's different, but it's different. See, let us see 5 feet. 5 feet का होना चाहिए 50 kgs होना चाहिए. 5 feet is how much centimeters?
I think 160.
Huh?
150.
152. 152 का it should show 50 kilos. 152 का? हाँ आ रहा है 50 kilos आ रहा है.
Calculation को exact sir.
Calculation is by
मैंने
chart.
check किया था.
You understand ना 50 plus height in inches, 2.3 to height in inches. You understand that, right? That is
So I
over 5 feet.
Yeah, I again go to normal one. So I set my height here. Then I get the ideal body weight. So for adult it is taking 100 ml per minute per kg. So that means if you are setting 100%, okay, you will get 6.6 liters of the minute volume. But suppose, as I said, if you have, a difficult patient, as in not with pneumocapnia, not with, you have fever, metabolic state, you want to target more minute volume. So as per your target minute volume, what you do is you can change the percentage minute volume from 100 to a little bit more to increase your minute volume target. Okay, so if you want to give more than 6.6 liters, then it is anyways in your hand. The limit is still 350.
So the only way, just to jig the system and make it more complex. So tomorrow, if you feel that the tidal volume is delivering is extremely low, you can't increase the minute volume. That is an issue.
Yes.
You are understanding what I am saying? So tomorrow, if the machine starts 100% minute volume, okay, and your tidal volume that it is delivering because of the Meads and Otis equation is say 4 ml a kilogram. Because of that equation is 4 ml per kilogram. You are just not comfortable with 4 ml per kilogram. You say that no, I want to change this. I don't want it 4 ml per. You are seeing 4 ml per kilogram, and I want to change it. Normally, you will go to the ventilator and just change the volume. No, here you can't go there and change this. It is not going to do that. It will still remain at 4 ml per kilogram.
This is affecting your minute volume.
Yeah. So the only way you can change that is by going back and changing the height. Are you understanding? You understand the issue? See now, in a normal case, say you have a patient on, you have set 300 ml tidal volume. Okay, that's 4 ml a kilogram. And now you came besides the ventilator, so 4 ml per kilogram. I think I want to increase the volume a little bit. It's not okay. I want to increase this. I want to make it 6 ml a kilogram. You feel that clinically, your intervention is I want to increase the tidal volume. In this case, if a patient is ventilating like this, if you increase this to 120% now, it may not increase the tidal volume because it is looking at an equation and giving you the least force and work of breathing. So it will give that only tidal volume. 4 ml, maybe it will increase the rate, maybe increase the pattern, maybe change the pattern, something like that, but it will not increase the volume. So when you increase your percentage minute volume, it is not going to increase your tidal volume. You are understanding? Maybe to increase that, you may have to go back and change your ideal body weight.
I have an
So
example.
why am I telling you this? Because tomorrow when you are ventilating a patient bedside, you should not see lower tidal volume, छोड़ो यार इसका tidal volume बढ़ाओ मैं minute volume बढ़ाऊंगा, ऐसा होने नहीं वाला है. It's not going to work like that. समझ में आ रहा है तुम लोगों को? हाँ?
I saw in a post of cardiac question.
हाँ.
Post of CA.
हाँ.
Because it's already post of athletics.
Yeah, exactly.
And
So
then what happens?
this is the problem. This is exactly the problem in cardiac surgery. In cardiac surgery, you have a sternotomy, FRC is low, collapsed lungs. All these are problematic. Once you open the sternum, your lungs get collapsed.
Now how ASV reacts is that because ASV always see the mechanics. Now since the mechanics shows the low time constant because of the athletics, okay, it always try to find out the optimum volume and rate, and it will wait for the lung mechanics to improve, which is not going to eventually happen in post patient immediately because once you extubate and then you start incentive parameter.
So then what happens is in a cardiac surgery patient, the bleeding just keeps on prolonging because वो होता ही नहीं है ना recruit, वो होता ही नहीं है because pathology अलग है उधर. It is because of atelectasis. Unless he does an incentive spirometry, it is not going to open.
Yeah.
Or you do a PEEP maneuver, it is not going to open. You are understanding the issue. So that is why when some people, when they are using in Belgium, when they use this Asv mode there, cardiac surgery, they actually keep the minute volume as 140 and 150. which is not defeats the purpose. If you do that, it defeats the purpose.
And even the cardiac planning anesthetists, usually they are very focused for volume.
Volumes.
They want more volume.
Cardiac volume, if you see a patient coming from CABG, they will be giving 800 ml, 600 ml, 500 ml, because it's not ARDS, they are okay giving higher volumes because they want the volumes to be big, the chest has to expand, chest has to expand.
One question. So if I want to increase the volume, already I have set the ventilator with prescribed height and all that. So can we go back and again change the height in a already? I mean.
Yeah, so you no back as in you can go in the controls only while the machine is on, and you can reset your height.
So everything will
Yes.
be again.
But you should not do that.
No, we
Ideally,
You should not do that.
Because in this option of the ASV, so once your machine is on, suppose, and in that also in controls you go to patient and you can manipulate the height and doing the ventilation. as well.
So when your very high-fi ventilation is going on, and you are understanding your T power, transport pressure, understanding insufficient pressure, and you feel no, I need a little bit of volume to get this better. After looking at all of these things, very high-fi ventilation, complicated ventilation, you may want to change that. It's like a very complicated ventilation. Okay.
Second question. So as a novice, what should be the? It should be like 100% of the minute volume every time, or like.
To start with.
So depending on the case. So 100% for a normal lung, ARDS higher, asthma lower, fever higher. Simple. And the higher is 10%. So 20 or 10%. So if it's 100, 80% for asthma maybe, 120% for fever.
And your other guidelines remain same because since you're not going to set peak of 5 for ARDS, you're going to set a little bit higher peak of 8 10. So that all remains the same.
ARD is also higher.
That is also higher.
And very important thing is this ASV limit. Which
This you must understand.
okay.
All the three values you just.
Sorry, why
All the three.
Yeah.
They are,
Yes. So the main parameter is these three. Now I have increased to 120%. You see the minute volume target is changed. Okay. So as per what your patient condition is, you have changed it and you got an increased target minute volume. Now this is important. This peak and effect remains same like other conventional mode. You can set as per your patient oxygenation. This thing, and the important part is the ASV limit. It is your upper pressure limit to avoid lung injuries. Okay, and this the default setting is 30, and ideally we also always want to maintain the pressure below 30. So this is the default setting. But in case you have patients of ARDS, okay, where we know that there will be a little bit of higher expectations in terms of pressure, you can increase it to 35, 40. But not too much as well. Depends again on the lung condition. You can manipulate that.
Basically, it's a plateau pressure.
Yes.
That you want to be below. You want to be below, okay?
Now,
That's another limitation because this is all alveolar, not chest wall. There's all that limitation. The usual limitation that comes in plateau pressure, that comes in way. Yeah.
So now, as I said, that for
So he wants to know the last other three also.
Okay. The other three will come separately.
It will come.
Actually, I just focus on the first parameter. Suresh will come on. I'll explain you that. Those parameters are for the synchronization, EPS and the PM and all, which will come.
In short, ETS is expiratory trigger sensitivity. 20 to 40% is what you want to do. COPD patients, you may want to keep it high.
For enhancing more cycling.
Cycling. It's there in all modes basically. In all ventilators.
Yeah, is there also. Especially in all the spontaneous mode, SIMV, spontaneous, you will get ETS. So as I said, therefore ideally it is taking 100 ml per minute per kg of the idle body weight. So ideally your idle body weight should, the patients who are more than 30 kg or equal to 30 kg, you are going to see this. Similarly for pediatrics, you will see 100 to 200 ml per minute per kg of idle body weight. Okay, neonatals, we were discussing instead on the actual body weight. Okay, but ideally, as there are no much studies for neonatal, okay, mostly ASV is being used very, very frequently in adults and pediatrics. Okay, so but for pediatrics, it should be less than 30 kgs, okay, or above 15 kgs. So in between 15 to 30 kgs, you are considering that under the pediatric category. Now PFI2, as I mentioned, it is the same.
30, no?
15, sir.
15.
Below 15, we are considering under the neonatal this thing. Then your circuits and everything gets changed again. And PFI2 remains the same as the similar controllers what we have in the conventional mode, and it is based on the patient oxygenation status and the target. Now what is the logic behind ASV? Now this is the main logic. So we are setting a minute volume target, okay, and now as per that Moore's equation, it is going to calculate the optimal breathing pattern. Now in that particular thing, whatever the minute volume you have set as a target as per the minute volume, it is going to make the combination in such a way that you always get a minute volume of 7.5. So if you have a patient of say ARDS and the machine analyzes that the patient requires less volume, it will give you less volume and a higher rate. So ultimately it can give as low as 150.
No, so let me explain this better. So what happens is, this graph is called as, forgot the name of the graph. This graph, no, it's not ASV graph. There's a scientist who made this graph long ago, which actually says that for a given minute volume, there are number of parameters that can make that minute volume. For example, you have 1500 ml and 5 breaths. And you have 50 breaths and 150 ml. So it plots all those points and gives you this particular graph. This is the first thing that it does. It doesn't mean that it is going to give 1500 or it is going to give 150 ml. It just tells that it creates a graph that gives you this minute volume. Okay, so if you make it 8.5, it will accordingly first create a graph. Clear on this? This is the first step that ASV does. Okay.
Now, so in that case, what Sir said, it is going to create all the maximum combinations to achieve the similar minute volume target. Now, this is the Otis formula. Okay, I want to highlight on this. Now, and as per the Otis formula, is going to calculate the minimum work of breathing. Okay, so ultimately your rate, which is being decided by the ASV, is done by this formula in the background. This is the algorithm behind which the rate is being decided. So, which is your constant divided by your time constant. This is the K for constant, okay, which the RC is your resistance compliance, okay, and we are talking about here the time constant value what we do, get on the machine, and as per that we get the equivalent.
So the equation is not so simple, okay?
Yes.
The equation is very large.
Very
it is
big.
simplified to this, sir.
So here the RC is RS and there RC is EX, that is the expected.
Yeah, so compliance is the
This is a respiratory. We are just generalizing it to a respiratory compliance and respiratory time constant. Irrespective of mentioning that as expert, yes, since we are calculating expiratory time constant, we take that as the expiratory time constant here to calculate that this thing.
Because the ventilator is trying to figure out what is the lung of the problem, and that is you can only identify in expiration in a passive system.
Now the time constant. So basically, the respiratory system time constant reflects the speed by which the lungs empties and fills. So in which the system changes its volume with respect to the pressure, right? So this is exactly the time constant, which is your multiplication of compliance and resistance. And this is how exactly you see in a normal value. So your normal value is from 0.5 to 0.7 seconds. We are calculating the expiratory time constant because we are using the proximal flow sensor, and it takes more than 75% of time the flow into consideration to be more accurate. Okay, because if I'm not using this and I'm using something here, okay, then my flow will not be more accurately considered and it will not be calculated.
You understand this? So what is coming from the AT tube is coming directly here. If I had my sensor here, this would change, this would split. And by the time it reaches there, the flow would change because it's in compliance with the tubing. So having a sensor here may not give you the actual flow that's actually getting formed. That's the beauty of this sensor.
So here we represent the normal time constant value from 0.5 seconds to 0.7 seconds, which represents normal lung mechanics. Okay, R normal, your resistance normal, your compliance normal, and you see here the value of compliance. Okay, 61.6 is the normal value of compliance, and 8 is resistance. Is also a normal value, and giving you this where you have normal compliance resistance combination decrease or increase. Let's see here ahead, and flow also you can see its normal flow time pattern. Now I go to a abnormal one. Now this is exactly your time constant influenced by the flow. What exactly we want to highlight here. And here, this is inspiratory time constant. Here, how it is measuring in the expiratory time constant, which takes almost 75% of the flow in consideration, to get the accurate value of the RCX. Now, I'll show you the other three in comparison. So you have normal, we have already seen, okay, where we have seen a normal time constant value by taking the expiratory flow in consideration. Similarly, your respiratory disease, it is shorter, okay, and your You see here the compliance is 22, your resistance is 10, and your time constant is less than 0.5. So if your time constant goes below 0.5, that means it's a short time constant, and particularly helping us to tell that it is a restrictive resistance. Similarly, if you go here, the time constant is more than 0.7. If you see in comparison with this, it's a long, expiratory flow. Now in that, which we have seen that the value of compliance is 70 and the resistance is 30. Okay, and which is what it is giving the time constant of more than 0.7, which is the obscurities. Now don't multiply R and C, you will not get that exact value. Okay, because as I said, for a normal condition, if you might multiply, it might give you an exact similar value of time constant. But if you multiply for obstructive or a short time or for restrictive, you will not get the accurate value once you just multiply. Because as I said, it's taking only the expiratory flow in consideration to be more precise and more accurate. Otherwise, if all the values, if I calculate, for all the these conditions, I should always get accurate value of time constant. And like this, it would have been more easy to also calculate in other machines. I just multiply the compliance and resistance, and I get a time constant value. Okay. So this is something where because this question comes from the users that okay, I can multiply the compliance and resistance and I get time constant. So it's not
because the issue is you have to multiply with the expiratory.
No.
That is the issue.
Yeah. So and the other is this because it's going to be more accurate that way.
And that is the problem with the other ventilators because they are also doing time constant, but they are doing it with the flow waveform and with the expiratory flow sensor
and the
distillate. So when a company comes and tells you that I am also giving you time constant, then you should understand the basic behind it as to why it cannot be accurate because it's not there. It's patent restricted. That.
Now at this point, if I want to show the normal time constant, okay, this is my patient height. I got the L value to 66. Okay, and my minute volume, is almost 6.6 liters, which I wanted. It's almost 6.7 liters, with a normal frequency, with your normal low expiratory pattern. Okay, and this is how exactly it shows with the normal compliance and all. So you can compare your dynamic lung, your parameters, your time constant value, and your tidal volume, how much ml per kg. And ASV will always try to give the minimum possible tidal volume ml per kg. That way, and it is going to try to minimize the volume also, even in normal patients. Because if you also see at 100%, it almost gives 6 ml per kg, not too much as well. So right now it is almost giving 6 ml per kg for 100% of the minute volume for the height of 170 and tidal value of 66. Even though this patient is a normal lung mechanics, but you may be needing more.
So, but what you must understand is, when you may see 8 ml per kilogram, you may see 7 ml per kilogram. Don't be worried. You may see 6, you may see 7, you may see all of these things. But it's doing this on the background of having the lowest work of rate. So, lowest work of rate. Your plateau pressures will still remain low. Your driving pressures will still remain low. You are understanding? Your driving pressures and your plateau pressures will still remain low.
Basically, it's taking our work on itself.
Yeah, so what you would do otherwise? You will see the driving pressure, you see the plateau pressure and change accordingly. What it is doing is, it will maintain the driving pressure, plateau pressure is very important, but the tidal volume may vary. So don't worry about it being 6 point, like I was saying 6.7 there, close to 7, don't worry about it.
Because this will be taken care of.
Plateau pressure and driving pressure. Because that's what's determining your lung injury. It's taking care of that.
Because it is made to the utmost focus of avoiding lung injuries, and with that, as sir said, that since it is giving 6 ml per kg only, and the volume also if you see is around 392. Okay, so almost 6 ml per kg, it is delivering to that 170 cm height. Now I might think that okay, is it less? This because this some this is a very general notion which come from any particular ICU or doctors who are using the ventilators. For them, they might be they want to give more 7 ml per kg or 8 ml per kg. So which is something we sir said not to worry. Now here I'll compare.
Sometimes they show I ratio 1:5.
It will do that on its own. So he'll explain. So what happens is, it takes the so the I ratio normally in a ventilator you are setting.
1:2.
You are setting it 2 set कर रहे हो ventilator पे. The beauty of this ventilator is the pattern of breathing. This I ratio is the pattern of breathing. How much inspiration, how much expiration, how much force, how much work, isn't it? This pattern is actually decided by the ventilator based on this complex otis and mean formula. So it may go from 1.1:1 to 1:3 to 1:2 to 1:2.5. It will do that.
And sir, it is also affecting ETCO2.
It will affect ETCO2.
So
But
when we accept that means yesterday that build up by it he had ETCO of 22, 23. I ratio 1:6 like that.
So that depends on what mode you see. If you see IntelliVent, I mean fully closed loop, then it will decide based on what target you have set. Based on what target you have set. So if you have set a target of 25 to 35, you can keep at 25 to 35. If you have 35 to 45, keep at 35 to 45. We'll do everything that makes it towards that.
Also, the patient's breathing rate was very high.
Yeah.
40, 45 breaths down,
But not regarding that patient. The
other
patient
one.
was there. He was not on IntelliVent. He was on
He was on-
So there if you want to ensure that his ETCO is going to prevent less injury. लेकिन अगर तुमको ETCO बढ़ाना है या कम करना है तुमको मिनट वॉल्यूम ही चेंज करना पड़ेगा. Minute volume change. That's what I'm saying. If the patient gets hyperthermic, he will produce more carbon dioxide. He will wash out more carbon dioxide. So if he's going to do that, you have to increase this.
So if the VTE is more than 1000.
It will not go like that. It will go
So
as
it
per.
goes that
So it will go only and only if there is an extreme change in the condition which will cause it. That's why I'm saying when it is very sick, no patient or very different, don't try to do this. Then that means a patient is sick. You need to treat that patient.
Now, in this particular case, when you said that the ETCO was less, okay, it was too less. In that case, you can decrease the minute volume so that it normalizes the ETCO.
So we have to decrease the
Minute volume. Because if he's spontaneous and if he's generating good volume, okay, and then the ETCO is too less. He was spontaneous at that time? No.
No.
No. It was passive.
No, he was spontaneous.
Spontaneous.
No, he was bed number
8 ना तो है ना वो spontaneous breathing.
तो TCC तो उससे लेने से आता पर फिर चालू था TCC तो लेने से जब प्ले गए तब से
So that is an IntelliVent.
तब से लेके
The permissive hypercapnia. Yes, that is the IntelliVent. I'll show you that. After that, it will come.
सर ने सुबह पढ़ा है.
minute volume.
सर ने मुझे बोला 10 और 8.
Yeah.
So this VTE we were getting like thousands. So what is it?
If it gives 1000. So actually what happened, I'll tell you. Suppose if you have a obstructive disease patient, now this can increase volume because the lungs will be hyperinflated, overly compliant. At that time it might give, but I have never seen, गया था किसी को? कौन से patient?
वही हम लोग को I ratio भी कुछ I ratio 1:7 तक जा रहा था.
What is the exact condition?
उसका कल एक्चुअली डे टाइम में क्या हो रहा था, when he was waking up ना उस टाइम पे
What is the exact diagnosis?
उसका
Is he obstructive?
no वो कुछ नहीं है actually. It doesn't he came with aspiration.
What was the setting then? We need to see that.
100 का
Because अगर today आज भी है तो हम लोग देखते हैं.
है वो.
Now this I wanted to, so for the short time constant, we already discussed this. So time constant is too less, the machine is giving less volume as per almost 4.6 ml per kg antibody weight for the same patient, and you can relate that with the dynamic lung, okay, which you see, so less than 0.5, which is too less, your time constant value, which is restrictive disease, what we have seen compared with this. Now then comes to your obstructive disease. So you have, so here it is giving now almost 778 of the volume, okay, which is in case if it is an actual obstructive disease patient, which is fine for him. I mean, they are asking about a patient which happened yesterday that giving volume of 1000. I said we can go and see that what exactly happened. So now this is giving because of the obstructive this thing. So it has analyzed the patient lung mechanics, which is time constant. This is so high. See 4.46, which is very high. So you would have, if you would have seen the same time constant there, it is too high, and because of that probably the volume has increased and the rate has subsequently decreased. But it will also not go into apnea. It might give minimal rate.
If a person goes into bronchospasm, the trigones will increase.
Yes.
This is what
Obstruction happens.
obstruction, though it will increase the trigon. What it will
Now this is the obstruction is showing here. Okay, in the airway, the peak pressures are also 57. Okay. So all this, parameters you can additionally see with that when your volume is raising along with the time constant value, then you will have a better, figure with you. Now here you see the obstructive part, your compliance is also high, resistance is also high, and which can possibly happen in all this condition: COPD, asthma, bronchospasm, ETT obstruction also. Sometimes there are obstruction clot or maybe clot, we don't know, and the volumes are going high because the machine analyzes the obstruction. Okay, and we think that this is some patient lung condition. We have not analyzed the even the HME filters.
What's the question?
So
if my patient is COPD, obstructive pattern,
Ah.
so I should keep a low rate as well as low tidal volume if I'm not mistaken. I mean to
So what it will do, no? It will actually study the characteristic. We don't know what is the characteristic of your lung. This is actually studying the characteristic of the lung. We are assuming that okay, COPD में ऐसा करेंगे.
But what we are taught ki decrease your tidal
So
volume.
it is at the end of the day we are doing that to improve or reduce the work of breathing. It is looking at that work of breathing.
So but now this
First is the
first is RR.
So it is actually looking at the work of breathing there and giving you the best possible combination to reduce the work of breathing.
So we can go up to this 770
Yeah.
it's very difficult to digest.
It does.
this.
It goes to 8,800, 900 also भी जाता है. It goes to 800, 900 also.
But how much the guideline says for you to COPD, like you said?
No, I really don't know
The COPD, because the guideline says for normal patient for COPD group guideline they say 6 to 8 ml per kg.
No, 6 to 8.
So 8 ml that you are acceptable. Okay. Now anything where the lung maintenance are totally more bad, as in more
So
obstruction.
remember this. What is your worry if you increase your volume? Your pressure will go up. That's your worry. But here there is a limit on the PASV.
Yes.
You understand? So वो plateau के ऊपर जा ही नहीं रहा है. You understand? Our worry is what? कि मैंने volume अगर बढ़ा तो मेरा plateau बढ़ जाएगा. That's my worry, no? लेकिन तुमने इसमें PASV limit लगा के रखा हुआ है. तो even though the patient is at 778, the PASV limit के नीचे है.
The limit you have set that.
Plateau pressure is
हाँ, उसके नीचे ही है वो.
So your lungs are safe.
Lungs is safe.
Even the studies says that on COPD areas they use ASV to always maintain least possible plateaus and least possible cardiac pressures.
So at the end of the day, that is your parameter.
so that set pressure is always flat pressure, not the
No, it is a plateau. So it's maintaining that that's what PASV limit is all about. It's maintaining that limit.
But also you said that for that patient yesterday, volume was very high. We may have to see all the possible causes of the obstruction.
At this moment it is maintaining
The
the
HIV is
blood
long.
pressure. It's not increasing.
We can see that.
Pressure down. Even if the
Or spasm also,
pressure is
severe
down.
spasm something.
So his question is, what if there is a bulla? So what if there is a bulla? If there is a emphysematous bulla causing this, something like that, which is a valid question. But the end of the day is the pressure, the plateau pressure is still down.
Still down.
Your bulla is going to expand only and only when your plateau pressure is going to change.
Right.
You understand it? If a bulla has to break, it will break, whatever it is. Okay, but the chances of it breaking higher if the pressures are high, not the volume. At the end of the day, it's the pressure that is going to.
But in that case, in COPD, they already have the bulla.
they already have bulla. So pressures.
So the emphysema,
No, if he is saying इसका टाइड वॉल्यूम इतना ज़्यादा आएगा तो क्या होगा? So
Right.
I don't have the real answer to this. But mostly what will happen is it is looking at the time constant and accordingly giving you the pressures to be on the lower side.
I think as and when we use, we will get to understand more.
Because it's not, when you are increasing the tidal volume now, it's not just increasing your tidal volume at that same inspiration. What it is doing is, your I ratio also changes. So if it is 778, you might wonder 778 is going in 1 second and 3 seconds is expiration. It is not like that. That 778 will be dissipated to maybe 3 seconds of inspiration and 1 second to expiration. You understand? It is changing that so that it doesn't, others your thinking is, there is a bulla here, full tidal volume will go to this bulla. It doesn't occur that way because it changes the I ratio so that it dissipates everywhere. The flow characteristics are changed. You understand it?
And ASV actually started in 1998 with only Otis formula, where it was only seeing the minimal work of breathing, and even the volume as per their idle body weight was a little bit at a higher side. And then they got a newer version, okay, which was almost launched in 2016, where they got 1.1 ASV percent, where it was reduced to 7.5 ml per kg, okay, and they included the MEADS formula, which also worked on the minimum force of breathing. So overall, less stress on lung, which part was also applied.
So one of the primary reasons that ASV did not pick up was it was 9 ml a kilogram, and just that it was exactly the time when the ARDS ventilator statute had come out, which said 6 ml a kilogram. So it really didn't pick up for a while till they found the MEADS formula.
And both this, will decide your breathing pattern. And there are two elements in common here. One is the time constant, which we will discuss, and the dead space ventilation. Now, this was a study which is done by Dr. John Michel and Anal. Okay. And here, if you see, they have done the study. They compared the normal lung, mild ARDS, moderate ARDS, severe ARDS, and COPD, where you see that how much ml per kg volume is delivered. Okay, with the plateau and driving, be at the safest, at the safest.
So you got that answer. So even if the tidal volume goes up to almost 11 ml a kilogram,
Yeah. millimeters.
Even if it's going to 11 ml a kilogram, still your driving pressure,
Yeah,
driving pressure and your plateau still remains. So you answers the big question, the 1000 ml se kya hoga? It's not going to happen. He's phenomenal doctor, Ramashan. Phenomenal doctor.
Yeah. Now defining the targets today. I mean, on this particular ventilator, we'll go also step by step virtually on the vent trainer to understand. So how we do that? First, we should have the ideal body weight. Okay. And how we are going to do that? We are going to set the gender of the patient. Very important gender also we have to set. Okay. And then the height, because all these formulas are already filled for gender, as per gender also female weight. So you will, this ideal body weight is going to be calculated by the user set height and the gender, and then the percentage minute volume based on your patient condition and the PCO2 targets what you want to get, and based on that you will get the target minute volume. Okay, I already showed that how you change the height, how you got the minute volume this thing, and how you still want to change the minute volume target. You can change the percentage minute volume as per your condition that you have seen. Now, how exactly it assesses the patient condition. So this is what a clinician defines. Of course, you are also setting the minute volume percentage. You are setting the ASV limit. Okay, as per your patient condition. Now it gives 3 test beds. Okay, under the 3 test beds, it is going to understand your inspiratory pressure. Okay, your total time required by the the pressure to reach, and your time constant. Okay, all that things is going to analyze after the 3 breaths, because if you start the machine, it will not give you initially everything. You see that first breath, second breath, third breath, and then it gives you the time constant reading. It analyzes, and then according to that, it gives you the. So after 3 breaths, you get the compliance, the time constant, okay, which will be from the patient is giving you, and based on that, your rate and volume will be decided. Now in that case, this is going to be your ASV algorithm, which is your Otis equation and Mead's equation, going to help you calculate target, RR and volume in the form of a ASV graph, which you are going to see in the next slide. So your loop is how getting closed. You as a clinician already said this. Machine gives test bed, analyzes the the patient requirement based on the patient's time constant. Okay, and after that, the ASV will plot a graph to understand what is the adequate volume and rate for this particular patient. And in that case, again, you can adjust. It will adjust the mandatory rate based on and the inspiratory pressure based on the patient's mechanics. The mechanics changes. Suppose the patient lungs become stiffer, the ASV increases the pressure, inspiratory pressure, and accordingly adjusts the mandatory rate.
So very interesting. I'll tell you something. Okay, something very interesting. You go through this. Okay, so if you have a patient who is high RR, okay, what do you want to do usually? If the patient got high RR, either you want to paralyze, treat the cause, whatever. Let's take that away. Treat the cause away as of now. Okay, we're just looking on a ventilation perspective. Okay, on a ventilation perspective, if the patient has got a RR and the patient is in volume control, what will happen? If the patient has got a fast RR, so let's take the example of any patient in the ICU. You have said volume control, and your RR is 20, huh?
For that many RR, same volume is given.
Exactly. So if you have set a RR of 500, if you have set a tidal volume of 500, every breath will be 500 ml. Irrespective of तुमने क्या किया है, तो patient has got a chance of going into respiratory alkalosis, right? Now what this ventilator does, So it's this close loop is so beautiful that if the RR goes up, sales taking lecture for them, Answer. So if the RR goes up, it will convert RR from volume control to pressure control. It will immediately convert the respiratory RR mode, directly the mode it will convert. You are understanding? To volume control. If the RR goes low, it will convert to volume control. You understand? So basically it is doing things so that it does not destroy the lung. Otherwise what will happen? Say the patient is in volume control. You are not around. And the RR is 40. You are doing some other work. There is no alarm ringing. So the nurse also doesn't look at it. But what is effectively happening? 40 ka breath mein, every breath is 500 ml. You are giving 20 liters. 20 liters of minute ventilation you are giving. Okay, which is going to cause lung injury, which is going to cause other problems that are associated with that. What this does, it converts that RR from volume control to pressure control. You know this, right?
Yes.
Beautiful, that is.
And reduces the volume.
You can understand this when you look at the graph. It's so beautiful.
So it will not give the same volume at those number of reps.
Yeah,
Reduce
exactly.
it.
Because you might think, अगर अरे वॉल्यूम ही देने वाला है तो वॉल्यूम हर जगह बढ़ जाएगा, वो ऐसा नहीं करता है वो. You understand?
And then as and when the patient compliance resistance changes, as in time constant, it will regulate the inspiratory pressures, okay, and adjust the mandatory rate, okay, to as per the patient's comfort. So you don't have to really worry in that way because it's going to auto. So now since it's adjusting the inspiratory pressure, it's working like more as a pressure regulated volume control, more when the patient is passive. Okay, so when the patient is passive sedated, okay, and it will decrease the pressure and try to give the best possible volume as per that patient's lung mechanics. So your pressures are anyways changing. Pressures are anyways regulating inside. Okay, I'll show you that as well in the vent trainer. So this is exactly how your
This is the main thing now.
yeah.
Okay.
So this is exactly how the ASV graph forms.
That box you see now, that box, this is what it is.
So this is the safety box which the machine makes. Okay, so it makes in red color, moreover, which you must have seen, I think. And in that safety box, okay, you will have a set target by the machine, and there will be a plus yellow sign which will be the patient, which will try to rotate in that safety box. And ASV will make sure that the patient should always remain in this safety box. Why safety box? Because the safety box is made in terms of eliminating all these abnormalities. So particularly if your volume goes high, of course we know the volume goes high, it will cause volume trauma, wire trauma. Moreover, if the rate goes high, it might cause autopeak, which okay, in the conventional thing what we always see. And here you see the part of lateral ventilation, and it will also, because the rate part, it will also never be apnea. Okay, and as per that mechanics, it is going to draw that safety box. Okay, and always try to eliminate this 4 abnormalities. Now, how exactly it happens for different abnormalities? Now, this is here for a normal, patient, normal lung mechanics, where your target bed volume is 6.6 liters. Okay, where your patient is generating 424 of the volume and 16 of the rate. Okay, as per the time constant of 0.67, which is a normal time constant. Now, suppose this is how it looks for normal lung mechanics. Okay, and there will be a small plus sign also which will rotate. We will do that in this thing. So this is a safety window. What exactly they mentioned. Now for this normal lung mechanics patient, it is almost delivering 400 of volume and 16 of rate. Now if I go, so if you have a wide square shaped window, a proper square shaped window at the middle of this, that means it is showing off normal lung mechanics. Please compare this shape of the ASV graph with the targets what it's setting, and also with the compliance resistance values and with the time constant. So you should have the 3 pictures. One is your time constant value, one is your dynamic lung picture, and one is your ASV graph. So all the 3 things you can see and compare, and you understand more better that it is a long. I'll show you that image also at the end. Now suppose if you have a low and a wider window, okay, that means your target is same, but the machine is delivering a lesser volume. It has targeted lesser volume and higher rate. Now if you see here,
Because higher volume, lesser rate means the RC expiration is low, means it is a stiff lung. It's ARDS.
so here you see the RC express 0.18 and the compliance is too short. I mean too less, 18 only. Okay, so that means it is, this patient has a restrictive condition, and with that machine analyzed it. It is a stiff lung, low compliance lung, and it has made a low and a wide safety window. It's still a safety window, but it's low and wider, and it will try to keep the patient in this window only. Okay, and so too happens in the obstructive cases where you have a narrow and a high safety window, where you have a long time constant. The time constant is 2.45. Okay, for obstructive disease, higher compliance. If you already seen this thing, okay, with the obstruction, and then it will give you a vertical. You can say high or narrow.
So if you have a patient whose tube is getting blocked or is coughing on the tube, they will just come.
You will see a graph like this. And it is very much prominent to see also the graph. You see that okay, it has made a wider window for volume and a shorter window for a rate. So now if you see this, can you just guess what exactly this is?
So what kind of disease is this? Exactly.
So your time constant. So what you compared is your time constant is less. Okay. Here if you compare the dynamic lung, this is also less, compliance is also less, and along with that, if you see the ASV graph, it has made a low and a wider window and have have set a target of 374 and a rate of 21. Okay, this plus sign is your patient is trying to meet the target. So this is your safety box here. So ideally this is a restrictive condition.
So what happens is, say for example, your patient is in here, your patient is here. Your patient is here, it will try to move this patient here by increasing the RR and reducing the pressures, reducing the volume. If the patient is here, it will do the opposite of that. If the patient is somewhere here, it will reduce the RR and increase the volumes. You know, this is what it's going to do.
And if you see the pressures also, it's almost delivering 20 centimeters of order of pressure to achieve this volume, because the patient is, you know, of restrictive disease. Okay, and suppose if the patient comes back to normal, it automatically reduces the pressure and it will try to give you that best volume in least possible pressures. And you will see, and even if the patient gets spontaneous, right now this patient is totally spontaneous, still generating a high pressure. Okay, but the patient is spontaneously breathing well
So
normally.
usually in the ASP you will find 99% of the patient being spontaneous. You will find that.
This high resolution picture is from a real patient. I have clicked from the pen drive and I have just attached to show. So you see the patient is breathing at a normal rate. His spontaneous breathing is there still. Okay, and he's generating a fair amount of volume and this thing. So I think this is I mean, you can accept this setting, right? And similarly to that, we will do the same thing in the background. Now, how to use ASV? We already seen that. I again show you that in the vent trainer. But let's just understand the contraindications. The absolute contraindication is leaks. Okay, now it could, so that's why we don't use ASV in NIV. But if you know the doctor from PGI Chandigarh,
Improved already.
no,
The other, the chest medicine kind.
the Sadarji,
I got it.
He has done a study on ASV and NIV.
Yeah, I don't know how to but he's done multiple 200 studies that time.
Yes.
And then one guy, PGI Chandigarh, he's a professor. He's junior to me by some years. Some years junior to me, I think so.
He's young.
More than 200 papers. More than 200 papers. That guy does a paper every day, I think so, the way he's doing it. He's a good doctor, excellent doctor. Aspergillosis का बाप है वो. But the people don't, he always wear aspergillosis forums. Aspergillosis के बारे में ही बात करते हैं.
So if you have a bronchocerebral fistula, of course because there will be leak, okay, inside, so you will not be able to, because AS will not get the accurate value of time constant, and then it will not be able to work. But then I think likewise other modes will also have similar issues, but you should not use that in those conditions. And other relative contraindication is the irregularly respiratory drive. Okay, where you see that the drive is very irregular, and when you're trying hard to settle the patient on ASV, it's not settling. At that time, you should then not wait for so long and change the mode. Now this is now we'll just so how we are going to do this as to start. So measure the height of the patient. Okay, as already said, once you measure the height, you're going to also select the patient gender. Okay, so you have adult pediatric category. You select the gender. You set the height. Okay, and once you set the height, you can do the initial settings, and those initial settings will be these three parameters. One is your percentage unit volume, PEEP and FI2. PEEP and FI2 is same like other conventional settings as for your oxygenation targets, and for the minute volume. So if your patient is passively ventilated, okay, your percentage unit volume is equal to your target minute volume. Okay, so if you set 6.6 liters per minute, it will give 6.6 liters per minute. Now you can increase this, okay, to reach the target PSU to whatever you want to achieve. Suppose if you want to wash out CO2, you increase it. Okay, if you think that it is in hypocapnia, okay, you can decrease it to normalize it, and that way you can adjust this. So if your patient is passive, it
So
can
that answers your question. You were asking, if your patient PSO was low, what do I do? You would have
reduce
accordingly changed this part. You understand?
and then the initial setting, as I said, will start from 100 or 110%, but you can increase as per your patient condition. Now, if the patient is spontaneously breathing, okay, your percentage minute volume setting will be equivalent to the minimum minute, ventilation. So that means, so suppose if you have 100% of the minute volume set, and the 6.6 liters is target. That means this is the machine target. Now you can reduce the machine target if you think that the patient is doing good. So when you reduce the machine target, if you reduce from 100 to 80, it will reduce from 6.6 liter to 5, say. So now 5.0 liters will be the machine target, rest all the patient takes.
It's like a backup.
Backup. And you can decrease to change your pressure support level. So as I said, that when you decrease this, that means you are changing the pressure support for the patient. So you're decreasing from 6.6 to 5. That means you're reducing the support from the patient. And you want the patient to breathe more that way. So when the patient is active and if you're increasing, decreasing, or suppose if the patient is tachypneic, okay, in distress, you can increase the minute volume to increase the support. Okay. So that way it will not have such that it will not have effect on the volume. Okay. So we don't really have to think on that context. That if I increase it, might increase the volume. If you are increasing in the patient's spontaneous breathing, it is going to help me increase my pressure support.
So ideally, you should have a bar that says work of breathing. Ideally.
Yeah.
Ideally, you should have a bar that says work of breathing. Work of breathing is how you increase the. That should have been the best way. That's what PAP does. Proportional assessment ventilation has got a work of breathing bar.
And the PEEP sets, all the settings are as usual what we do. Now these are the main parameters. So these three are the main parameters, and this you're asking about the additional parameters. So sir said about ETS, which is your expected trigger sensitivity for your cycling, which is normally set in between 30 to 50%. So 40% is something default which is set on this, but you can increase it in case if you want to enhance your cycling and more synchronization part. Similarly, your trigger part is also same like other machines. You can adjust your flow trigger as per that, and your ramp is your rise time. Okay. So
ETS is the percentage of flow.
percentage of flow, yeah.
Okay.
Indirect flow setting. And similarly, your
flow
ramp-
40% पहुंचेगा तो it will expire.
It is like pressure support. Cycling.
It is a cycling expiratory trigger sensitivity.
And then you have a P ramp. I hope you know about the rise time. Okay. And the only name is different here, which is P ramp, which you can measure in milliseconds, ideally. And the default setting for this comes is around 100 milliseconds. Okay. And you can again decrease, increase as per your.
So you really don't need to touch these parameters. This is kind of standard. In
Yeah.
very severe COPD, you may want to change this, but otherwise.
And the ASV limit, again the default set is 30. Okay. And it is low. So in this particular part, your ASV limit is set as 30. Okay. But if you have ARDS and other things, you can titrate your ASV limits to how much ever you want to achieve. Now weaning, for weaning part, we have this weaning window, when status window, which I have showed you. Initially I was showing about the entire chart of the weaning windows. Now it has got daily screen of readiness to wean. Okay. Now in that it screen and analyzes that how in the observation phase for how long it takes a patient to remain in that weaning zone. It shows that, and then weaning trial, and I'll show you that part of weaning list. Now this is your when status. Readiness to wean criteria. Now in this particular thing, when you have some parameter outside. This is the parameter outside of the range. Okay. It is not started any timer. Okay. But once it has come here to almost 75%, the RSB is still not there, because once it crosses the 75%, the RSB, which is your rapid slow breathing index, will start coming. Okay.
Because you need to first
spontaneously breathing for
RSBI.
Yes. So once you get that, so it is still outside range. Now your patient lung mechanics looks normal, everything fine here. Okay. And it is doing the screening phase now. Okay, then comes the observational phase. Now, this is where your all parameters are inside. When the patient comes more than 75% of the breathing, your RSB starts appearing. It gives you a green window, okay, a green border with a timer where it will start observing the patient. This is the observational phase. Okay, so screening phase, then observational phase, where you again this part remains the same. Okay, and now this is what is your all parameters in the range, and this is exactly your SBT trial has started when the timer actually starts. So in your observation phase, it will remain 0, 0, 0 same. Okay, it will analyze for some time, for half an hour at least, and then it will go to your SBT part. Any parameters goes out, it will abort the SBT.
And it will tell you which of the parameters gone off by a screen on top.
Yes. And even each parameter will have separate timers, where you will understand that this particular parameters remain for how long. So you can also individually monitor those each parameters.
So you can actually say after so much time you got tired, so the
I think
changed.
we are done with here. Then I'll just show you on the vent trainer how things are changing. Okay.
So when the spontaneous breathing attempt fails, you will have the indicator that says white failed. Whether it was low tidal volume, whether it was IRR, whether it was RSBI, whether it was FiO2, whether it was spontaneous breaths, it will come on that. Accordingly, you should decide, okay, this is what I want to do. You understand? If the patient is too sedated, it will not probably, it will say that there is no RSBI is not coming in place.
So can we just start from?
Yeah.
So can you help me to do any?
Let's set the ventilator.
Yes, set the ventilator.
Arshad will set the ventilator. Tell from there what you want to do.
So suppose we can give a case so we can start.
Okay, so your patient will basically come in because he was just out of being a stroke patient whose GCS is 8/15. You decided to intubate him because you wanted airway protection. Now you intubate. You will set the ventilator.
So first we'll go to re-op check.
All that is done. Re-op check is done.
Re-op check is done.
Okay, height.
Okay. So we first set the patient category. Already set everybody. Then.
Okay. So ideal body weight.
I said it's a female. What do you do?
Female.
It's a female, right?
Yeah, it's a female.
So we'll select the
Female.
patient category. We'll change to female. Okay. Then I set the.
Say quickly. You don't be dumb. Say quickly. Whatever you see, what to do.
Height उसके हिसाब से weight उसके हिसाब से tidal volume.
You set the height. What you want to set, you tell him on the ventilator.
Height.
How much you want to set?
So his height is 180.
180.
Okay.
तो उसका tidal volume should be 8 ml.
नहीं. What are you going to set? अभी क्या करना है? इसके बाद क्या करना है? कौन सा बटन दबाना है? ये तुम्हारा ventilator है.
You got tidal volume weight. Now what is the next step?
You go ahead. What button you have to? कौन सा बटन दबाना है तेरे को बता. He will only do what you are telling him to do. Go there. Go stand there. What are you going to touch now?
Okay. Unit volume percentage. So I go there.
No. Let him do it. No. How? Let him do it.
I'll operate from here.
Okay. Check. Okay.
Okay, apart to 100% will set. The percentage volume, how much you want to start with?
8 180. 8 ml per kg. 8 liter.
No. You want to help him, Ganesh?
Yeah.
So you call for help. See, he is more attentive than you. Who the eagle sitting outside.
First we'll set the gender of the patient, which is already set. We'll take the height of the patient, which is already done. We want initially we will go by 100% of ventilation and
Simple.
speed 5 and FiO2 we can come on 50-60 and we start the ventilation.
So I just come down and we start ventilation. Let's see what happens. Set I say 70 example. I start the ventilation now. Let's see now. We have got the ASV graph also.
So you have the graph. Now from the graph, what can you interpret, Arshad? From the graph, from the parameters that you can see, what you can interpret?
Restricted, sir. RR is also low and volume is also low, sir.
Ganesh, agree with that?
Why are we saying restricted?
Because the graph is closer.
So the RC expiration is 0.7, so it's like 0.5 to 0.7. So
How can that be restrictive? What will happen in restriction?
RCS is more, sir.
What will happen in restrictive?
it will be less than 0.5. So
ये सोलह था क्या Arshad?
So this is 0.74. It is like little high, not too much. Okay, and with that, so now the machine has given 3 test breaths. Analyze this compliance resistance in the form of time constant. Okay, so which you are right that it is more or less normal to little bit, right, little high, and it has made this safety box. Okay, and it has targeted the volume of 490 and the rate of 14 for this patient. So far, yellow is the patient plus sign which is trying to rotate in this only, and it's there only, it's meeting the target. Okay, so it's achieving this this thing. And if you compare also the dynamic, so this 1, 2 and 3 I'll compare. Okay, my compliance is more or less normal, okay, 64, very slightly high, but my resistance is also fine, and my safety box is also okay, and it is generating almost a pressure of 9, okay, to achieve this good volume. Okay, because she was a female and the height is also 180 cm, which is a good height for a female that way. So it is generating that much of volume as per the minute volume. Okay, now I change some parameters. Now I change and I'll show you what exactly happens. Okay.
Better, sir. Ashok, you must listen carefully, otherwise you will not pass the exam. These are simple things.
percentage of volume.
What's the question?
So she says कि oxygen अपने हिसाब से adjust कर सकते
Option अपने होता है. That is purely what we want to do. Like any other ventilator.
So I'm trying to change something, and you will see that what's happening.
So now what has happened now? Can somebody come and tell us what has happened? Nikhil, can you come and say what's happened? So he's done something, and now you are walking across the ventilator, the same patient you're walking, and you come and see this. Now what are you seeing, and what is your inference?
The RC is that it was slightly on higher side. It was showing slight obstructive pattern. Now it has come down. It has become 0.36. It has become lesser than normal.
And what are you seeing on the dynamic lung?
It has become more restrictive kind of.
Exactly. What has happened to the box?
The box has become it is showing more respiratory wider.
It has become
more
wider.
respiratory lesser.
And what has happened to your target?
But target is still achieved.
Target is achieved.
So your time constant is less, which is restrictive.
The target is achieved.
Yes, still target. So ASV tried.
So this entire box is safe.
Safe, yes.
Entire box is
So
safe.
initially, if you see, the outside was trying to push that the plus sign target to target the patient to target. Now it has achieved it. So what we could guess that there is a change in the mechanics of the lungs. Why change? Because the time constant reduced. It is restrictive, and it is also showing low compliance.
Obviously, you'll come and see what is the patient, what has happened to her, is there atelectasis, what is happening. This is what you'll come and see basically at this stage, because there has been a marked difference from what the patient came with and what the patient has become now.
Now, if you see the volume target change, initially it was around 480. Now they changed to around 337. It's almost achieving 330.
So what would have happened otherwise? Say it was on volume control, and the same restriction is occurring. What would happen? Your plateau pressure would have gone over the roof. Because the same volume is getting delivered. It was 600 or 500 or whatever. The same volume is getting delivered, and then your plateau pressures would have gone, and that would have caused injury to the lung. This has not caused injury to the lung, but at the same time, it is telling you do something. There is something wrong. You understand? It is not caused injury to the lung. Given you time, and you have to decide what is to be done.
So this is just achieved target.
Yes, just achieved target. But even if it might remain inside also.
Still it is safe.
It is still safe. So sometimes it will rotate inside the box, but might not reach the target. But you still don't have to worry. That way. Now, suppose now this part has we already saw on the graph. Okay, here we are safe with body trauma. Here we are safe with there is no autopsy. Okay, there is no dead space and there is no apnea. I do again little bit changes to see.
And now identify what's happening. Okay, identify what's happening now. Okay. So it has intelligently changed the pressures. If you see 13, 14 kar diya, 9 say, it has done all those things. It's increased the tidal volumes, the controls, frequencies. Same after explaining this without a problem.
So can you see any changes a little bit?
RR का volume बढ़ गया and
The RC, EXP, yeah. So what it has done?
RR reduce the RR from the 20
Volume को बढ़ा दिया.
volume बढ़ गया obviously constant बढ़ गया.
Now here is more interesting. Why? Because your time constant still looks to be in a little bit of normal range. Okay, your compliance is reduced, but your resistance is increased. You can see this redness on this. Now, if you get such graph, okay, where you see that in the mixed condition, ideally what happens, it will not give you that accurate graph like that. What it does is it will give you a little upper, higher graph, and it will give you a mixed, sort of situation where your time constant value looks to be normal, and you say whether it is not restrictive or not obstructive. But at the same time, what you do is, even though it looks normal, okay, you can see the compliance resistance and see the graph. Okay, now graph will tell you exactly that this is shifted a little bit at the upper side, okay, and it has showed a mixed condition where it's giving you a good volume as per that patient height and weight. The patient is still in a safer zone, and it has made a safety box as per the mixed condition. But otherwise, what happens in obstructive condition, it will make you vertical window, in restrictive it will make you a horizontal window, and mixed condition it will make you somewhere in the middle or the top, like that. Okay. Where in mixed condition your time constant value might be
It might be same because of both together.
Because of both together.
Same.
So I try to create a mixed condition here where you can see the obstruction also and the restriction also.
So graph is showing more like restrictive.
Little more because it's mixed condition. No? Now
And their airways red.
red, yes. So
So
we
it's
need
got both.
It's got
So if you
both.
look at the graph, it's got a restriction as well as an obstruction. It's got both. So basically, you have to look at the context. You cannot just look at one number. That's exactly what we're trying to tell you. Look at the context of what's happening. Okay, and this ventilator will give you that context by giving you all sides of the story. Yeah. Any questions? We're done. Any questions?
So I hope you understood with
It's actually very simple. It's actually really, really simple. But any given moment,